Okay, let me go ahead and share my screen, and we'll likely give people just a minute or two more to join before we get started in case anyone's coming from another meeting. Okay, we will go ahead and get started. Dr. Heidi Diaz, our pharmacist and co-program director, is going to be leading the panel today, but I'll go ahead and just walk us through some housekeeping and intro slides with the CME and everything before we get started. So just as a reminder, live attendance for these meetings does qualify for CME, and to get the CME credits, you would text 66610 to this number that's on the screen. We will send out the slides to you shortly after this, and this information is also in the handout that LIFA sent out prior to the meeting as well, so it should be in your inbox. And then you just have to complete the evaluation by September 3rd in order to get credit. We're able to offer medical CME, nursing CE, pharmacy CE, and dietetic CPEU for attendance at today's webinar. And then just disclosures for anyone who's speaking on our planning committee. Dr. Ashman has some stocks in publicly traded companies, in Abbott, AbbVie, Johnson & Johnson, Merck & Co. So we're very lucky to have our panelists here today. Please let me know if I mispronounced your last name as going through this, but we have Frankie Dyack from South Valley Medicine. We have Heather Kiefer here from Holland PHO, Dr. Caitlin Pierce from Michigan Medicine, Dr. Jagdish Sachdeva from Oakland Southfield Physicians, and Lindsay Lott from Michigan State University. And Heidi, can I go ahead and hand it over to you to kick us off with our first question?
Absolutely. Jackie, I'm having a little trouble downloading the slides, so if you don't mind just advancing them for me, then I think we can stay on task, if that's okay.
Yep, that sounds great.
All right, so hello everybody. I'd like to take the beginning to have the panel speak to a couple of group questions, and then we're gonna move into some very directed questions at our panelist. So the first question posed to all of you is, I was wondering if you could explain the structure of your practice and talking about the different clinicians or staff that collaborate with you on patients who have type 2 diabetes, and what their roles are in your practice.
Perfect. Do you want to call on someone to start first, Heidi, the panelists?
Sure. Yeah, no problem. So Dr. Pierce, you're the first person I can see, so I'm going to call on you first.
Sounds good. So again, I'm Caitlin. I do outpatient internal medicine at one of the U of M Michigan Medicine clinics. And our practice organization, we have about 5 primary care clinics participating in MCT2D. So we have internal medicine and family practice, but I'm internal medicine, but everything is pretty similar because we're all part of the same organization. So we have our providers, MDs, and we have APPs. And I think we do have a lot of multidisciplinary staff, which is really, really helpful. So like Heidi's not at my clinic, but we have PharmDs, usually 1 or 2 per clinic. And their role, actually, they can prescribe and adjust medications. We basically have an agreement where each provider signs something once a year, and we work really closely with our PharmDs. So that's a big part. And basically, we usually use it very well by the PharmDs. We'll do a lot of counseling and actually medication adjustments, and it's especially helpful when starting new medicines, like especially GLPs for titrating up and managing the insulin if they're on that at the same time. So that's very helpful. And we have our RNs. Our clinic RNs don't have a really formalized role other than some education, because we also utilize the diabetes education group through the endocrine department through Michigan Medicine. So we often send new diabetics to that group for, initial education, nutrition, that kind of thing. We have also nutrition, general nutrition, and our MCT2D group at our Michigan Medicine have a specific low carb nutritionist, which has been very helpful. She will only do low carb counseling for our patients. And then something that's relatively new that is actually a very important part of the team is through Michigan Medicine, some clinics, not all. So for some reason, internal medicine, but not family medicine has this. We have prior authorization kind of pool we can route medication issues to for prior authorization, cost checks. And so they are pharmacy techs. I think family medicine, those groups have a MA, but we've really found that the pharmacy techs have a lot of the expertise. So that's kind of an overview of our specific, primary care group that and all the staff and multidisciplinary team, but we also have endocrinology, but that's just through primary care.
Thank you so much. Moving on, can I have Heather speak to the same question?
Yes, absolutely. So again, my name is Heather Kiefer. I work with Holland Hospital Medical Group's Internal Medicine North. So we have about 5 to 6 practices here in Holland that are participating in the initiative, but I really just had threw some notes together for this practice. And so here at Holland, here at Internal Medicine North, we have about 6 physicians, 3 nurse practitioners, and a physician assistant. So in addition to those providers, we also have 2 full-time diabetes education specialists that support just this office in person. And then we also have at least a minimum of 1 CDCES in each one of our locations in those other 4 to 5 locations. In addition to that, we have 2 pharmacists that support all offices. They do some in-person assistance or med reconciliations and meet with patients, but I would say the bulk of their work is done via phone. They also weigh in on a lot of prior auths and issues with coverage and help kind of get involved with our prior authorization team as well. They're a huge asset, I would say, in connecting specialties, with this being kind of the topic for today. We also have 2 care coordinators that sit off site, and they try to help support in the background with coordination of care, especially our patients that are a little bit more complex or high risk, in having communicating with those specialists, specialty departments. And then we also have a community social worker that supports all of our offices. Again, like, she can come in person to meet with patients, but does a lot of phone-based support and helps with helping patients, kind of with social determinants of health issues there. And then we also have a full-time behavioral health specialist here in the office, as well as all offices, to assist and really help place all patients that are having additional struggles with depression, anxiety, or substance abuse and such. So they are quite the asset in helping connect some specialties as well. And the last one I wanted to touch on is we have about 3 full-time registered nurse triage positions, and they do a great job at in reflecting with some of my providers before this panel. That was the position that they felt really bridged our practice to specialty care the most when it's care outside of our medical record. And so they do a really good job of calling these specialists and having conversations about the patients just to help bridge that gap. And so that's kind of a nutshell of what our practices offer.
Thank you so much, Heather. Is Dr. Shastava on the call? I can't see any more faces at this point. Maybe we'll give a little more time. Is Frankie on?
Hi, everyone. My name is Frankie Dyack, and I serve as the practice administrator manager for a medium-sized solo practice. We have 1 primary physician who splits his time between inpatient and outpatient. He's also the program director for Trenton Beaumont here downriver. He has 15 internal medicine residents. We also have 4 mid-levels and 1 PharmD. part-time. So what we've been able to do, we see about 4,500 to 5,000 patients uniquely a year, about 25,000 visits. We are the typical solo practice, I suppose, and we have the struggles of the resources. However, having the residents rotation through here, we're able to assign the interested parties to plan visits that's aligned with PCMH for diabetes. So we've been able to give them a registry of patients to follow year after year. So when one resident graduates, we would impart it to another. So we've been able to really follow some high-risk patients. We have partnerships. We have a huge building, so we've started to kind of bring in some specialists. We have behavioral health and clinical psychologists for behavioral health that's now in the building. So that is one of our goals for this small community in Trenton, Michigan.
Thank you so much, Frankie. Moving on, I'm pretty sure I saw Lindsay on here, even though I can't see your face right now. Lindsay, do you mind telling us about your practice?
Sure. So my name's Lindsay. I work at MSU, and currently we have 2 primary care practices, but only internal medicine is participating at this point. We are looking forward to adding the additional endocrinology and family practice in the future. Currently, we have about 9 attending providers and 1 nurse practitioner. The joy of my current location is that we are also in the office with endocrinology. So we have the privilege to be able to ask them questions or also gain more knowledge about different medications as well. So that's been very nice when talking about collaboration with different specialty clinics as well. Right now, I'm a nurse care manager, so I kind of drive the program within my clinic, and I have another nurse, Jessica, who works with me as well. We have developed kind of the idea of we look at the schedules, we target patients that we think would be a good candidate for a CGM, let the provider know, the provider has the conversation with the patient. We've also been really working to educate our providers on optimizing medications. So starting to look at those SGLs and GLPs as well to kind of say, you know, let's try this on a patient, see how it goes. We have MA staff, there's 3 dedicated to the internal medicine side, and they are letting myself or Jessica know if any patient, we do point of care A1Cs in the office. So if they test at an 8 or above, they come and get us right away. We don't have PharmD. That is something we are looking into and definitely see the benefit. And we recently within our organization just hired a diabetic nurse educator. But she's still working to kind of get things up and going. So we are hopeful that we can start sending more patients to her for more education and help with management as well. But right now it's pretty much 2 nurses and working very closely with our providers and MA population to work on getting diabetes more controlled, filling those gaps in care. Our MAs are in charge of kind of doing all the chart prep to make sure we're hitting those eye exams, foot exams, labs that are required for diabetic patients as well.
Thank you so much, Lindsay.
Oh, sorry, we do have social work too. I apologize.
No worries. So thank you all for giving us kind of the vision of your practice as we move through these questions. Moving on, I was hoping.
I'm sorry, do you have me listed? I'm Dr. Salah. I don't think you have my name there.
I did not have you listed. Are you filling in for Dr. Shastrava? By any chance?
No.
No?
I believe I registered for the conference today, you know.
Oh.
So told me I'm registered at 12 o'clock. So.
Oh yeah. Well, I apologize, but do you want to share with us your practice layout?
Yeah. So Okay, I'm Dr. Sala. So I'm an endocrinologist here in Dearborn. So I have 4 nurse practitioners with me. So we have a busy practice here. So we are close to Bowman Dearborn site, and then I have 4 nurse practitioners with me. We have like about 5 medical assistants. One of them just dedicated for prior authorization and CGM download. And we have another one also to help with the diabetes education. My nurse practitioner will help with that as well. So it's always struggle really with the, obtaining the PA and keep up with those. So my practice probably 80% diabetes and probably 70% diabetes, 30% the other endocrine aspects.
Wonderful. Anything else to add before I move on to the next group question? All right. So now I would like each of you to share with us where gaps still remain on your team. And here's the magic wand moment. If you could add additional time or staff, what changes to your care model for your patients with type 2 diabetes would you do to improve? And so maybe now I'll mix it up a little bit. Heather, you want to go first?
Sure, I can get going. I can start things off here. Let's see. So I had jotted down, it would be great to have additional in-person support for patients. As over the years, we've really seen that we've had to centralize some of our roles to be more phone-based so that they can touch more individuals across our systems. But we definitely see huge improvement in kind of follow through and patient engagement when we're able to offer it here in the office and face to face. And I think that has a lot to do with our population being a heavy Medicare population here at this particular location in Holland. And then I had also said additional support with so with us, specifically with patient assistance applications and follow-up, as this can be very time consuming for the diabetes education role within our office. And so we're working through trying to recruit some additional support there, but that would help better our patient success, I think, and bridge gaps that we might have.
Okay. Thanks, Heather. Frankie, can you share with us your thoughts?
I actually second what Heather was saying. A lot of our gaps still do exist in the follow-up and education. Being a diabetic myself, I know that it resonated with me when I was first diagnosed with my first pregnancy, that I said, Beaumont at the time, Beaumont Royal Oak, sat me down with a diabetic educator. And the first thing that I remember, and I still recall to this day, are the portion sizes in plastic, fruits, and all of that. Because that resonated so well with me, it's difficult to try and find prompts like that for even our providers to educate just on portion control. So I think at some point, I don't know how this particular group or initiative goes further, but I do believe that, I know there's shortage everywhere, but I think we all can, agree that nutrition and RDs are the biggest shortage for this population. And if anyone is at all close to that educational pathway, that we should invest in sending people to get trained. Just my 2 cents.
Thank you, Frankie. Yes, and I think expanding coverage of said services would also be quite beneficial. Dr. Pierce, do you want to answer this question for us?
Sure. So again, I'm at Michigan Medicine, so an academic primary care clinic. So we have a lot of resources, but kind of like what the previous people were mentioning, it's accessing those can be an issue. So to get into diabetes education, sometimes it's 2 or 3 months. Nutrition is 3 months. So, we love having these resources, but it's just a busy system. Access is difficult. So that's a gap. Ideally, we get people in within a few weeks for especially a new diabetes education visit with our diabetes education team. And we also, another piece is we do notice with the prior authorizations are so cumbersome and very annoying for everyone. So 2 out of our 3 clinics have the specific pharmacy tech group that does it, which is pretty good. It's still kind of burdensome, but when we talk to our other 3 clinics who don't have that specific centralized pharmacy tech, it's still a lot more work than we have. So that's a big barrier because the medications are so effective. So getting them covered is a big barrier as well. And I feel the other clinics were talking about or organizations were talking about how they can actually pre-chart and trigger the providers, say, talk about a CGM. Do we need to do some of this? So we don't have anything like that. It's hard with the number of providers we have and the number of clinics and the volume. That would be very nice. And kind of going along with that is CGMs. Our whole we're not very good in primary care at CGMs. So that's a big barrier with multiple pieces, but a lot of it is the getting them covered and then after the fact downloading the data and billing for it, which would take, our providers we're probably not going to learn how to do it. So more additional help from that standpoint. We've identified a gap from there.
Thank you. Dr. Salah, can you comment about your practice with this question?
Actually, in private practice, we don't have enough resources. As the our colleague said from University of Michigan. So we really have to do the best we can do, like educating the patient on site. We have diabetes education program at Bowman Dearborn. We utilize that, but that's still not enough resources, because I think that site they have 1 certified diabetes educator working there. So it takes many weeks until the patient get to be seen over there. The other struggle, like I shared what the others said about the prior authorization, it's a big obstacle, really. Just you like to utilize those wonderful medication. The problem, it take a lot really to get them approved. And when they get approved, they're wonderful medication. They help people to lose significant weight. I mean, with the newer medication, you see, numbers which we didn't see before. We get some new diabetic patient, referred to us with hemoglobin A1C above 10. They already on insulin. We add GLP-1 medication, and then you see them after 3 months, and their numbers we never seen that before. Numbers in the 6 and 7 range, which is that's a big achievement. The problem, it take a lot. I have just 1 or 2 medical assistants just dedicated to work on the prior authorization. It's become very costly and very tedious to do this, in addition to utilizing the CGM, get to download the CGM and interpret that. It is very good for the patient, but it is time consuming. So it needs a lot of time and a lot of effort.
Thank you so much. And last but certainly not least, Lindsay, do you mind sharing your thoughts on this question?
Yes, I mean, echo again, we need help with prior authorizations. Right now, our 4 triage nurses are in charge of working those prior authorizations, and they're very time consuming and tedious. So if I could have an additional person to work on prior auths, that would be great. And also a dietitian or a nutritionist that could talk about low carb. I myself do the education, but I feel like I just am giving a crash course just to get them kind of started with and to think about things. We do utilize a diabetic medical center of Sparrow and McLaren, both offer classes, but again, it can take a long time to get in there. So access availability is definitely an issue. And then I would love to have PharmD to be able to speak to my primary care providers about the new medications. I have a lot that just don't know a whole lot about the GLPs and the SGLs, and they get a little apprehensive to start them because just a lack of knowledge. And I feel like I can speak to it minimally and I understand the benefit, but to have a peer be able to talk to them about the benefits, what they, things they need to look for or be cautioned with other diagnoses would be really helpful.
Thank you, Lindsay. And I always like to hear, PharmDs are in need and how we contribute to the team. So thank you all. I do want to move on. There was a third group question, but in essence of time, I want to make sure we get to some of the focus questions. And then at the end, I want the audience to be able to ask you questions. So moving on, I will probably go in order of Dr. Pierce, Dr. Sala, and Heather on this question. So how does your physician organization help support your staffing to provide team-based care? So Dr. Pierce, do you mind going first?
Yeah, so I think our organization does a pretty good job. Again, we're a big system. We have a lot of resources. So we have endocrine support in our same system, which is very easy. We can easily message endocrinologists. Access is tough, but they're still available. We use their house in endocrinology. We use their diabetes education group, which again can take a few months to get in, but is very extensive and effective. I think for specifically primary care, having the support of the PharmDs, they're very integrated into our clinic. Our two at our clinic have been here for years. We all know them. And that is supported at the institutional level, which we found really, really helpful. And then more recently, even this prior authorization group, I don't even know where it came from. One day they said, oh, you can route to this pool, to the pharmacy techs. Again, only at 2 out of the 3 clinics. I think it's just internal medicine right now. And that has been, it's kind of been a game changer. Sometimes, when they're in the coverage gap, it's a mess, it doesn't get covered, but they do a lot of that work that would otherwise, maybe one of our MAs would have to do it, or our nurses, and they're already overwhelmed. We have staffing shortages like everyone else from that standpoint. So, and those are specifically from, Michigan Medicine. They support it for not consistently through internal medicine and family medicine, but family medicine does have PharmDs. All the primary care clinics do. So that has been really been so helpful for the team.
Thank you. Dr. Salah, do you mind answering this question next?
Yes, but I don't think this is applicable to my practice because we really don't have physician organization, in our setting.
Yeah.
So we have to rely on ourselves, what we do in our practice. So
perfect. Yes, I understand. So thank you. And we'll move on if Heather doesn't mind answering this question.
Yeah, absolutely. Well, if anybody can remember to the laundry list of physicians that Holland Hospital PHO supports and access to, that I feel like we are very fortunate to have even my position within the office as long as we have. And I think we all realize that, but we try to utilize all of those positions. And I feel like our offices, we've now had those positions, care coordinators, care management nurses, nurse triage, diabetes care education, behavioral health, and pharmacist. I could be missing some. For let's say roughly 4 to 5 years. It has expanded over the years in practices, but I will say that has just the investment in that they have seen great success with and improved care, improved outcomes, numbers, metrics. Any metric we really check is improved. Patient satisfaction is there. They're just happy to have the support and services. And so that's where I would say we gain the most support from our organization.
Thank you, Heather. All right, moving to the next question. This one, I think, Jackie, you need to go. Oh, yes. For Lindsay, Heather, and then Dr. Silla, I think you're listed here, but this one might also not be applicable. So I'll call in Lindsay and Heather first, and then if you want to chime in at the end, please feel free to do so. So Lindsay, do you mind commenting on how you keep the patient a center of your team?
Sure. So being a care manager, that kind of comes second nature for us. It's very patient-centered. Anytime I'm working with one patient, it becomes one-on-one, customizing goals and plans all to them. So meeting with them, starting them on a CGM, hopefully, and then kind of seeing where their barriers are. Is it access to food, making sure I'm addressing all those social determinant of health needs. Is it a lack of education? You would be surprised at how many patients are a diabetic, but nobody's ever really truly explained what that means, things that they need to watch for, and understanding that it's very manageable and kind of taking that time to explain that. So I try to build like a whole self-management for them, with them, listening to their voice and kind of setting goals that relate to them and what they think they can do in the moment. So again, that's just me being a care manager and kind of what I've done for the past 10 years. But even with my assistant, Jessica, I mean, we both, listening to that patient individually, working with them to see what works, and then collaborating with their PCP to see how we can effectively manage them on a one-on-one basis.
Thank you. Heather?
Yeah, very similar to Lindsay in that, I'm really happy that medicine has been moving in this direction and moving away from, well, this is what I want you to do. But really having a conversation with the patient, like, what do you think, using motivational interviewing, what do you think is going to be, the best or the most impactful change right now, and why? Providing education, but really trying to lick that change from the patient to see the most sustained long-term change. We also, so I don't know if this is what you meant with the question, but within our medical record, so the patient calls in with a concern, we'll open we call it like a telephone encounter, and then we'll use that to communicate with patient, provider. We can send that to any of our interdisciplinary specialties that I've gone over, and we will not close that out until the concern has been fully resolved. And so that's just a great way to track and get everybody's input, and then also patient input, and kind of keep that running until the situation is fully resolved. And so that does help a lot with making sure that patients are not falling through the cracks, or concerns are not going unnoticed and such.
Thank you, Heather. Dr. Salah, I actually might go off script here and ask you a question about how do you, as an endocrinologist in working with primary care physicians and teams, allow the patient to know that they have two parties that are truly working together for them?
Yeah, that's actually very important, because we have to work on multiple levels here, really work with the patient, work on the primary care physician, because it's good because for me, I round in the hospital, like at Bowman Dearborn. So a lot of my referring physician, I see them in the hospital. And a lot of time, actually, they ask question about the newer medication, especially with the GLP-2 and then the GLP-1 and SGL2 medication. So, education is very important, because, sometimes if you are not in good communication with the primary care physician, sometimes the patient might end up having some of those medications stopped by the primary care provider if we are not on the same page. So at the same time, the patient needs to be very, educated about those medication, adherence with those medication, the expectation, especially with the, at the beginning when you start somebody, with the GLP-1, the GI side effect, and just, to educate them what they have to do in case they have side effect, not to stop the medication, how to do, with their diet changes, and behavioral changes to, to help achieving the goal. And that's very important to, just to have a better outcome.
Thank you so much.
Thank you.
Moving on to the next question, Dr. Pierce, this is going to be all you. So I'm hoping that you can talk us through your thought process, or if you have any strategies for how you refer to all the amazing resources we are lucky to have at Michigan Medicine. So dietitian, and maybe even comment general dietitian versus Stacy focusing on low carb. Then also how you refer to my fellow colleagues, and then moving on to specialty, which patients do you decide to maybe send off to endocrinology or nephrology, and are they seeing, say, PharmD at the same time, or do you decide between both?
Yeah, so again, Michigan Medicine, we have a lot of resources. We try to refer everyone who's a new diabetic to diabetes education and or nutrition. So that's kind of a baseline referral. Again, it does take a few months, but we have that resource. We try to utilize it. For PharmD, we don't refer all patients to PharmD. I don't refer every patient who we start on SGLT2s or GLP-1s, but if they are on like glipizide or insulin, I almost always refer to PharmD when we're starting a GLP-1 or SGLT2, just because our PharmDs will call them about every 6 weeks, and they're another great resources for especially titrating insulin and following up on blood sugars. Our nurses will do some of that, but we have okay access for our PharmDs right now, so that's, I mean, I almost always refer to our PharmDs for that. If they have really low bile blood sugars and just want more, especially education on nutrition and diet, because our PharmDs will do that as well. And they also manage blood pressure, and we'll check on that for all the diabetes visits. Or just anyone who is, maybe low health literacy, or they're just very new to diabetes. I think we have a great collaboration with our PharmDs. If I refer someone that maybe it's kind of a light referral, I just want them to kind of get some more information from our 2 PharmDs and have some, have them kind of assess how is their understanding, how is their management of their own, lifestyle changes. And then they will say, like, send me a message, FYI, I met with them a few times, they're fine. And then we'll kind of go from there. For nutrition, our providers aren't great at this, but we are really trying to refer more to low carb nutrition. But a lot of our providers, me included until MCT2D education, didn't know a lot about the low carb diet. So it's not something that comes to mind, short visits, hard to do. But we kind of, especially patients who aren't really interested in medicine, say their A1C is above 7 or above 8. So not horrible, but they need something pretty intense, then I always try to push actually for a low carb diet. So that's referring to Stacy's our nutritionist who does the low carb diet. So I really try to encourage patients if they need more than just regular nutrition. Our general nutritionists are great too, but we've seen a lot of great, quick decreases in A1C with the patients who are consistent with low carb diet. So that's kind of the nutrition versus low carb. And then endocrinology or nephrology, I think our providers do a pretty good job with the SGLT2s and GLP-1. So we don't really refer for that, but if they're on max dose 1 or both, or have contraindications or having trouble managing, or they have a lot of comorbidities, then we'll utilize our endocrinology colleagues. And then nephrology, the same, if we can't control their diabetic nephropathy or their creatinine is getting worse. Luckily we have not great access, but we can get people in within a few months, or more if it's closer if it's urgent for our specialty colleagues.
Thank you, Caitlin. And I can just say the PharmDs appreciate those light referrals at times too. And then the other thing I wanted to add is just the intercollaboration. Dr. Pierce mentioned having Stacy doing low carb. The PharmDs are also working very closely with Stacy as she's helping them lower the carbs in their diet. We're working alongside to, decrease insulin and decrease other medications as need be. So I think it is a great model of complete teamwork. So,
and another thing I forgot to mention that we've been so lucky with the PharmDs is we've had two providers in our clinic leave somewhat unexpectedly in the last year or two. And honestly, our PharmDs have been just managing their diabetes for the last year until we hire new people. Of course, they rarely have questions, but if they do, we're always, the covering providers are available to collaborate, but it's been so helpful.
Okay, so next question. I think we're moving on to Jackie. There we go. This one, we're gonna have Heather, Lindsay, and Frankie provide answers. So what has been the key for your practice in creating successful collaborations with specialists? So Heather, I see you on my screen, so I'll call on you first.
No problem. So I really tried to discuss with a couple of our providers in this office, what they feel like is the biggest kind of key role in that successful collaboration. And that's where they had identified what we would call the position, the RN triage role. So our registered nurses that can, kind of, so I'll see them all the time coming up to our providers, having discussions with them once they deem it a little, maybe urgent and can triage things, and getting that information firsthand verbally to the provider. And then the provider is able to say, okay, well, go ahead and, either get them on the line or, I would recommend then going to they'll give them the recommendations right there. And so that role has been very, very helpful. And then our medical assistants can also get specialists on the phone. We are able to collaborate, maybe I would say quickly or easiest with our specialists that are internal because we share a medical record, but I can say it gets really difficult sometimes accessing chart notes and, making sure that we are following up with specialty care providers when they don't participate in, like, for example, Great Lakes Health Connect or Viper. Those are the two main ones that I know of that we utilize. We have an endocrinology part or like a department program just starting up this year at Holland Hospital. And so that has been huge. And obviously I've noticed just a better relationship because the lines of communication are a little bit clearer and shorter because they're internal now. And we're able to do a little bit more for patients. I'm able to find out how far we're booking out and talk with, an endocrinologist pretty quickly to say, would you be able to get this patient in? Or, what would you recommend? And so that's been very, very helpful and not something that I was able to do before we had that on site. And so that's really what our providers had, the input they had given me.
Thank you, Heather. Lindsay, do you mind answering next?
Sure. Like I said, we actually share office space with our endocrinology department. So it has been very nice. Our providers can kind of collaborate with the endocrinologist, but also as myself, getting newly diagnosed diabetics or diabetics that PCP just hasn't been able to manage as well and thinks that they need to go to the specialist, kind of working in collaboration, saying, like a nice warm handoff to the endocrinologist. This is what we've done. This is kind of what we're lacking. Do you want anything prior to their appointment? Or if I'm still following the patient, even when they are an endocrinology patient, I have direct access to the endocrinologist to say, here's where their blood sugars have running. What do we want to do? Do you have any suggestions? So we've really been successful with endocrinology, but also running into those same barriers that Heather was speaking of. We don't have nephrology within our own system, along with, the eye exams and foot exams, podiatrists. So we have an issue getting those records sometimes, even when we are the person sending the referral. So it's having our MAs and nurses work very closely, contacting the office, trying to ensure that we're getting those records to make sure we're also coordinating that care. Asking them to please send us any consult notes when they're seen. So it's been a struggle as far as outside collaboration, but we are kind of working through that by just contacting and trying to create a relationship with them.
Thank you, Lindsay. Frankie, do you mind sharing with us your thoughts?
So yes, for a private practice with no as much resources as everybody on this panel, we're having to ensure that we're able to manage the conditions within our own four walls. So as I said before, we do have some partnerships, long-term partnerships that we've been able to collaborate with closer. So we have in-house podiatry that's been with us for 7 years. He's here once a week, and we're able to directly refer those folks there. Our ACO does all of our eye exams twice, 3 or 4 times a year. We do have an in-house pharmacist that do assist our providers in ensuring that they're on the right dosage medication, helping with prior authorization and getting that approved through the plans. We have mid-levels that are available. We have 30% of our daily schedule open for same-day appointments. And I think that just kind of thinking on this a little bit, it does help to make sure that access is available to the patients because of the issues we have with specialists being out for so many weeks or months. So giving access to patients, so when you do have a compliant patient and their blood sugars are high, that they can get in and immediately see one of our mid-levels immediately to try and resolve the issues and have some of that education and conversations right away. We have the consistent planned visits with the residents, and as they're learning as new residents how important it is to keep the patients engaged, making sure that every 3 months before they even leave the office that they have a visit. So the consistencies I think that we've been able to maintain because we have that accessibility to our providers really help our patients far reduce their A1Cs just with medication and the assistance of the providers. It would be great to have endocrinology closer to us, but unfortunately we don't have that luxury, like I said. So they do maintain, they do a great job at maintaining here. Conversations with specialists, the importance of making sure the consult notes are timely. And if they're not, our staff and our EMR has a system in which you can we're reminded every 2 weeks of a tickler. It states that, patient, have you actually gone to make this appointment? Have you gone? Where's the results? All of the things that's required for the providers to actually do that. And so lastly, we just entered into, again, keeping in mind, we are a, private practice. We entered into a collaboration with a company called MedSend, who's going to be doing a lot of our patient monitoring, remote patient monitoring for blood sugars, as well as the chronic care management in between the visits. So I think we're going to be able to capture a little bit more of the measures and maintaining the patient's blood sugars during this time. That's one of our focuses, as well as our blood pressures. But for the purposes of this panel, I think that's really going to help.
Thank you, Frankie. Dr. Salah, I wonder if I can call on again and put you on the spot, but flipping this question, given that you've mentioned your private practice endocrinology, if you could share with us perhaps an example of a great success you've had with collaborating with primary care, and what are some of the attributes that have led to this success?
Yeah, so, as we mentioned earlier, and the group mentioned, this is very important. So when we're managing the patient, because, I would say 95% of the patient, they come to our office referred by their primary care physician. Probably 5% of the patient come self-referred. So those patients who come, I'll make sure, after we see the patient, they will get the note to them probably as soon as possible. Sometimes if I feel like something very important for the primary care physician to know, I will just communicate with them directly. If there is something serious going on with the patient care, it's very helpful when we share the same medical record. Then we can see what's really happening with the patient prior to their visit, what medication they tried on before. And the struggle will be when you have a patient coming from outside the system, if we are not using the same EMR, then it's going to be quite challenging. So, the staff, they have to call the primary care physician office to get the list of their medication and what they tried on before and their lab and so forth. So, you see, this communication is very important and is a key in the success of patient care. Also, for us, we have to be in communication with other specialists as well, because quite often we see patients, they come to the office, they have either feet infection or feet ulcer, and then we need them to get to see podiatrists as soon as possible, sometimes same day. Sometimes we have to send them to the hospital if they have infection need to be treated with IV antibiotics, or probably they need surgical evaluation. And the same thing with ophthalmology. Sometimes patients come there is a significant change to their vision or something we can pick with our exam. Then we have to get them to see ophthalmology like, very soon.
Thank you so much.
You're welcome.
So moving on to our last question before we open it up to the audience. So we'll go Dr. Pierce, Lindsay, and then Frankie with this one. If you can comment on any of the collaborations we've discussed today, where you run into some challenges, and then if you can share with us anything you've done to overcome those challenges. So Dr. Pierce, I'll call on you first.
So for our Michigan medicine clinics, even though we have all these resources, sometimes access is an issue, like I mentioned. So one thing we noticed at the beginning of our group and MCT2D, these 5 clinics, it was a long time to get to low carb or to get to nutrition, and none of us really had the expertise to really do true low carb nutritionists. So with the support of our practice organization, we were able to hire a nutritionist, Stacy, who just does low carb nutrition. So we had that availability, and she does all Zoom, but she has really good access. We can get patients in within a few weeks. So we still, have some issues of providers referring because they're just not as familiar with low carb diet. But that was a piece that our organization was missing. So adding Stacy, the low carb nutritionist, has been really helpful to actually get patients doing low carb diets.
Thank you so much. Lindsay, can you provide an example?
So I would say the program in and of itself has pointed out a lot of areas where we want to make improvements. And since this is our first year, it's dietary nutrition, one of the biggest ones, having PharmD. We definitely saw there's that lack of, there's so much possibility, with a patient, it's to see endocrinology or PCP, that possibility of we don't have to wait 3 months to make adjustments, but we do need people to be able to follow up with them, having the extra bodies. So we are definitely identifying the challenges that we've had in collaboration of trying to manage our patients from this, and it has brought some things to light that we are currently working on trying to hire, partnering with our own pharmacy that we do have here on site to see how we can maybe offer PharmD within our clinics. We did just hire a diabetic nurse educator, and now, we're Michigan State University, we have dietary nutrition college. So starting to have talks with them about how can we collaborate and bring people in. So there's still challenges for us, but at least the program has been able to identify them, and we've been seeing what the benefit could be and learning how to try to tackle this.
Yeah, making steps, so congrats. Frankie, do you mind sharing your thoughts on this question?
Everyone, I think, has that whole nutrition challenge. For us, I think CGM, because it's such a useful tool for providers. I need to connect the providers closer to the information the data that makes it helpful for them to titrate medication. So we are just like I said, stepping into this chronic care management and RPM program that has no initial investments from our side, which would help us be able to remotely monitor patients on CGMs and not really wait for prior authorizations for them. So I'm really encouraged that we haven't done it yet. This is our first week and we're going to be rolling out, but I'm really encouraged by the hope that we would get timely, same time data and information from CGM remotely right into our EMR, being monitored by the provider, just so that they can get to the patients and get them fully engaged. And I do believe that that communication will increase the engagement from the patient side.
Thank you, Frankie. And you said this is via the MedSend that you.
MedSend, yeah.
Yeah.
I've been looking at companies for over a year now for this. I've seen companies that require an amount of investments right off the get-go immediately for these devices. They're offering, to provide them for, obviously they have some sort of algorithm that identifies the patients that are already covered. So they cut through a lot of that already. And so they give us that data of the patients that we can immediately work with. And so that cuts through a lot of their losses immediately, which is a great thing. And so we're able, the ideal situation is on your EMR, there's a button, the provider would, pull that down remotely, enroll the patient on what device, and then that's basically the order. And so making it easier for the provider and getting those steps closer from the provider to the patient while they're talking about it, I think will get the engagement part, which is really where we fail a lot of our patients, is they talk about it and so much time happens in between. And then you're asking somebody at their next visit, how did you do with your, did you take a log? How did you do? A lot of that question will get answered with all that data should be flowing in, ideally.
So just to clarify, it helps with the ordering of said devices, CGMs or glucometers. It doesn't necessarily help with the downloading of the data from the CGM.
Oh, it does.
It does.
Goes right into, it goes right into our EMR. If you were to put a tickler in for 2 weeks, a provider can look right into the data and see how they're doing. They could reach out in between saying how they're doing, or I need to see you, it's not doing, medication, or I'm sending another medication in, or I'm changing your medication, immediately having that feedback.
And these are, they work with Abbott, they work with Dexcom, they're all able to work together?
Correct.
Great. Well, you'll have to keep us all posted on how
will.
that goes, because I haven't heard of that. So thank you for sharing.
Sure.
All right, we just have a couple of minutes left. So if there are any questions for our panelists, I would love for you just to unmute and ask a question before we wrap up here.
Also, feel free to put a question in the chat if you're more comfortable submitting it that way as well.
Yes, I'm here looking at chat, so. Give it 10 more seconds in case somebody's feverishly typing away a long question. All right, Jackie, you want to close us out? Oh, you're not.
Thank you. Thanks so much, Heidi, for moderating the panel. And thank you very, very much to all of our panelists. It was really helpful to hear from you all about how you navigate some of these complex challenges. We will, like I said, send out these slides right away afterwards, so the CME information is on there for you. We'll get this recording posted on YouTube too, so that you can reference it or share it with colleagues who weren't able to attend today. And then the CME handout should be in your inbox from prior to the meeting as well too, that has those same directions. And thank you so much everyone for joining. We really appreciate it. Have a great rest of your day.
Thank you.